Welcome back to the deep dive. This is where we, take those really complex, often critical subjects, and we really try and get into the source material, strip away all the noise, and just hand you the synthesized knowledge you need to feel, well, truly informed.
That's the goal.
Today,
Yeah.
we are tackling something that's, it's foundational to modern medicine, but it's also become a bit of a lightning rod, hasn't it?
Mm-hmm.
Lots of confusion, maybe some misinformation swirling around.
Mm-hmm.
We're talking about the rapid expansion of organ donation.
Right.
And specifically, we're diving deep into this mechanism called donation after circulatory death, or DCD. We want to look at exactly how it stacks up ethically, medically, logistically against the more traditional path, donation after brain death, or DBD.
Yeah, and look, this is an area that's just undergoing massive transformation. We've looked at sources, clinical perspectives from major players like Mid-America Transplant, the latest hard data coming out of UNOS, that's the United Network for Organ Sharing, and it all shows this topic is, well, it's critically important right now.
Why right now specifically?
Yeah. Because there's this risk, misinformation. Sometimes it gets fueled by maybe rare, really extreme cases, or perhaps comments that get taken out of context, maybe from officials even. And that risks undermining the public trust. That's decades of trust built up in the transplant system.
And that trust is everything, isn't it? I mean, when you're talking about a system that literally decides who lives and who dies, the stakes just couldn't be higher.
Precisely.
So our mission today really is to cut through that. Let's clarify the really strict ethical standards that govern DCD. Let's reveal the, frankly, explosive growth that's made it such an engine for donation. And maybe most importantly, let's look at the outcomes.
Yeah.
How successful are these DCD organs?
And it really matters to you, the listener. Why should you care about the difference between DCD and DBD? Well, right now there are over 100,000 patients on the national waiting list. 100,000?
That number's staggering.
It really is. And DCD, it's not some fringe alternative process anymore. It is absolutely vital. It's an indispensable part of the organ supply, contributing, thousands of lives saved every single year. So understanding how the system keeps its integrity while expanding its capacity, that's essential.
Okay, let's do it. Let's unpack this. And I think we have to start where the concern always seems to start, and frankly, where the system needs to be absolutely ironclad: trust and ethics.
Yeah, you really can't overstate this. When public trust in the sanctity, really, of the donation process starts to erode, the entire system is in jeopardy.
The whole thing could crumble.
Absolutely.
Yeah.
We're talking about a medical system that orchestrates tens of thousands of life-saving transplants every single year.
Yeah.
If people start hesitating, if they don't register as donors because they doubt the process, lives are lost, tragically lost.
So we need to be crystal clear about the safeguards. What are those non-negotiable rules, the ones governing organ procurement in the U.S., especially when we talk about DCD cases, where the timing around death feels so sensitive?
Okay, the rules are rigorous, they're legally mandated, and they're all built on this fundamental principle, you hear it called the dead donor rule.
The dead donor rule.
Right. The absolute bedrock is this: death is always legally declared by the hospital's own attending physicians before any organ recovery process begins. There are zero exceptions to this, period.
Before anything starts.
Before anything. And if the patient is declared dead based on circulatory criteria, that's the DCD pathway, that declaration itself must confirm irreversible cessation of function. Irreversible.
Okay, and this brings up something critical, that operational separation.
Sure.
How do you guarantee that the hospital team making that incredibly profound decision, the decision to withdraw life support, is completely separate from the people advocating for donation?
Yeah, that separation is absolutely paramount for ethical integrity. It's literally built into the structure of U.S. healthcare. There's a critical firewall, really, between the treating hospital team, the doctors and nurses caring for the patient, and the staff from the organ procurement organization, the OPO.
OPO.
Right. The OPO team is strictly walled off. They do not influence, they do not participate in any way in the decision to withdraw life-sustaining care. That decision, that deeply personal one to take someone off a ventilator or other support, that's made solely by the patient's family in consultation with their clinical care team, the attending physicians, the intensivists, the nurses.
So the OPO isn't even in the room for that conversation.
Not for that conversation. They only step in. They only even approach the family to discuss the possibility of donation after the decision to withdraw support has been finalized, made, and documented by the patient's clinical team.
Okay, so there's a clear time separation.
Yes, and it's absolutely necessary. It ensures that the withdrawal of care is based purely on the patient's prognosis, what's best for them, and the family's wishes completely divorced from any potential benefit of organ donation down the line.
Right. And I think, what often causes the most public unease, maybe, is that timeline right after support is withdrawn. What happens in that really delicate window? What if the patient, rallies unexpectedly?
Okay, this is exactly why the specific withdrawal and, crucially, the cancellation protocol is so rigorous. When the withdrawal process begins, it's usually moved to an operating room or a designated area. The OPO surgical team is there, they're prepared, but they are absolutely mandated to wait.
Wait for what exactly?
They wait for the declaration of death. But during that process of withdrawing life support, if the patient shows any unexpected sign of recovery, any physiological improvement, maybe they take an unassisted breath that lasts longer than expected, or their blood pressure suddenly stabilizes, maybe the heart rate improves when it shouldn't, the process stops immediately.
How far does that stop go? Does it just pause or?
No, it's abandoned entirely. The donation process is called off. The medical team immediately reverts to providing care for the patient, full stop.
Wow.
The commitment to that patient's dignity, and frankly to the public's trust, it completely supersedes the opportunity to recover organs, even life-saving ones. It's an incredibly emotionally charged moment. It's resource intensive to get everything ready. But if that cancellation criterion is met, the OPO team has to leave. That protocol is designed specifically to safeguard donor dignity, ensure there's zero conflict of interest driving the patient's care in that moment.
It sounds incredibly brittle in a way, but necessarily so, right?
Hmm?
The commitment to the ethics, to the absolute certainty of the declaration of death, it has to come before the desperate need on the transplant list.
Absolutely. That's the only way it can work. This entire framework is designed to ensure DCD is carried out safely, ethically, and ultimately effectively. It's this continuous vigilance, this willingness to walk away if the protocol isn't perfectly followed, that actually allows DCD to expand the donor pool without compromising public confidence or violating that fundamental dead donor rule.
Okay, so with that ethical foundation really firmly established, let's turn to the medical reality. We need to clearly define these two pathways, DCD and DBD, because they're fundamentally different, aren't they? In terms of procedure, timing, how the organs are preserved biologically, even though they both fall under the same legal umbrella, the Uniform Determination of Death Act.
Yeah, they're very different in practice. The essential difference comes down to how the patient is legally declared dead, and that how dictates everything that follows, especially concerning how long the organs can survive without continuous blood flow. This gets us to that crucial concept you hear about, warm ischemia.
Or ischemia.
That is the single most defining factor. It's the enemy in transplantation. It's the time an organ spends at body temperature without oxygenated blood.
Right. So let's start with the traditional route, the one that's been the primary source of organs for a long time. DBD, donation after brain death.
Okay, so in DBD, the patient has suffered some kind of irreversible catastrophe, maybe a massive stroke, a traumatic brain injury resulting in the total, complete loss of all functions of the entire brain, and that includes the brainstem. Legally, medically, the patient is deceased.
But the heart is still beating.
Often, yes, because mechanical support, like a ventilator keeping the lungs going and maybe supportive medications helping maintain blood pressure, is still provided. The heart continues to beat. And this is the key difference. The organs, heart, lungs, liver, kidneys, they are continuously perfused with warm, oxygenated blood right up until the moment the surgical team actually begins the recovery in the operating room.
Ah, okay. So that warm ischemia time we talked about is basically zero or minimal until the surgeon clamps the vessels during the recovery surgery itself.
Exactly. Minimal warm ischemia. That's precisely why DBD donors have historically been so valuable and why they often yield a full suite of highly viable organs, heart, lungs, liver, both kidneys, pancreas, sometimes even intestines. It's been the gold standard for maximizing organ yield.
Okay, that's DBD. Now let's contrast that with DCD, donation after circulatory death. How does that declaration differ?
So DCD is the pathway used when a patient hasn't met those strict criteria for brain death. Maybe there's still some minimal brainstem function, for example, but they've suffered a devastating injury or illness, something with absolutely no hope of neurological recovery. And critically, the family, in consultation with the doctors, has elected to withdraw that mechanical support.
The family makes the decision to withdraw support.
Yes. based on futility of care and the patient's prognosis. Once that support is removed, the patient's body naturally progresses towards cardiopulmonary arrest. Death is declared only after the heart and breathing have completely stopped, and this is crucial, remains stopped for a specific period.
You mentioned a standoff period earlier. Can you elaborate on that?
Right.
Why wait 2 to 5 minutes after the heart has stopped?
Right, the standoff period. It's typically 2 to 5 minutes of confirmed asystole, no heartbeat, no electrical activity. This is a vital ethical and physiological safeguard. It's mandated across the board to definitively confirm the irreversibility of that circulatory cessation.
Irreversibility is key.
Absolutely. We're specifically guarding against an incredibly rare phenomenon called autoresuscitation, sometimes called the Lazarus effect.
The Lazarus effect, really?
Yes, where cardiac activity could theoretically spontaneously restart after a brief period of cessation. It's exceedingly rare, maybe documented a handful of times in specific circumstances, but the mandatory 2 to 5 minute wait ensures that any return of circulation is biologically impossible. It guarantees the criteria for death by circulatory standards are unequivocally met before any surgical intervention for donation begins.
Okay, so the wait guarantees irreversibility.
Exactly. And crucially, after that declaration is made, the clock starts ticking very, very fast for the OPO team. Organ recovery has to proceed rapidly because the functional warm ischemic time, the time the organs are without oxygen, has now officially begun.
That time pressure sounds immense. But the statistics, the reality on the ground, show that the system, the transplant community, has somehow absorbed this pressure. DCD is fundamentally transforming the U.S. transplant ecosystem, isn't it?
Yeah.
What did that 2024 data from UNOS really show?
The data is, well, it's staggering, really. For the first time, DCD is undeniably the dominant driver of growth in deceased organ donation. In 2024, the U.S. hit a record high, nearly 17,000 deceased donors overall.
17,000.
Yeah. And look at the breakdown. DCD donors numbered 7,280. That represents approximately 43% of all deceased donors. Almost half the entire pool is now coming from the DCD pathway.
43%. That's huge. And what about the trend for DBD, the traditional pathway?
Well, this is the real shocker, the part that highlights the shift. While DCD numbers jumped by a phenomenal 23.5% in just 1 year from 2023 to 2024.
23.5% increase.
Incredible, right. Simultaneously, DBD donors, although still the numeric majority at 9,706, making up about 57%, they actually decreased by 7%. Decreased by 7%. And this is the first recorded annual decline in brain-dead donors after years of steady, maybe slower, but consistent growth.
Wow. So DCD isn't just adding to the pool, it's actually filling a gap, offsetting a decline in the traditional source.
Precisely. It underscores that DCD is now the indispensable engine for just maintaining, let alone growing, the national organ supply.
Okay, but there's a nuance here, right?
Yeah.
You said DCD is 43% of the donors, but why did they only contribute about 33% of the total transplanted organs? There seems to be a mismatch.
Yes. That's the yield disparity, and it comes right back to that issue of warm ischemia time and organ sensitivity. Those 7,280 DCD donors contributed 13,496 organs that were successfully transplanted in 2024.
Check.
Compare that to the 9,706 DBD donors, the 57% majority who contributed closer to 27,600 organs.
Okay, so the math breaks down. Let's see, roughly 1.8 organs per DCD donor versus
about 2.8 organs per DBD donor.
Right, nearly one whole organ less on average from a DCD donor.
Exactly. Historically, the DCD process, because of that warm ischemia hitting sensitive organs hard, was often limited. You could reliably get kidneys, which are pretty resilient, maybe lungs, maybe a liver if conditions were perfect. But historically, hearts, pancreas, very rarely viable due to that ischemic damage.
And that 1 organ difference per donor, you multiply that across thousands of DCD donors.
Yeah.
That represents thousands of potential transplants that didn't happen, thousands of people still waiting.
That's exactly right. That is the gap. That's the challenge the entire transplant community is racing to close right now. And the major breakthroughs we're seeing, things like successful DCD heart transplants, advanced machine perfusion techniques we'll talk about, they are all aimed squarely at increasing the yield, the number of viable organs we can get from each precious DCD donor, trying to push that 1.8 average closer to the 2.8 we see from DBD. Okay, so this naturally brings us to maybe the most technically challenging, in some ways the most ethically complex part of the whole process, the procurement itself. Especially for DCD, this entire procedure is defined by that race against time, the absolute need to mitigate the damaging effects of functional warm ischemia.
Right. We keep mentioning warm ischemia. Let's really break that down. What is happening at a cellular level, the absolute moment circulation stops in a DCD scenario?
Okay, think of it like this. Warm ischemia is the enemy of every organ, every cell. Without a constant supply of oxygenated blood, the cells can't perform their normal energy production, that's aerobic metabolism. They're forced to switch to a backup system, anaerobic metabolism.
Which is less efficient.
Hugely less efficient. And worse, it produces toxic byproducts like lactic acid, which lowers the pH inside the cell, creating an acidic environment. At the same time, the cell's energy currency, ATP, those stores deplete incredibly rapidly. Without energy, the cell's structures, especially the delicate membranes around the mitochondria, the powerhouses of the cell, they start to break down. And this damage, it's cumulative. It starts instantly, and it gets worse with every passing minute. It fundamentally dictates whether that organ will function immediately after transplant or function with delay or perhaps not function at all.
And in DCD, unlike DBD where perfusion continues, that damaging warm ischemia clock starts ticking the second the heart stops and that standoff period ends. So what does the actual operational timeline look like for the surgical team poised in the OR?
It is brutally tight. After that 2 to 5 minute standoff confirms irreversible asystole, and death is officially pronounced by the hospital physician, the surgical team has to move instantly. They need rapid surgical access, usually a midline incision. Then immediate cannulation of the major blood vessels, typically the aorta and vena cava.
Cannulation meaning putting tubes in.
Exactly. Large tubes or cannulas are inserted so they can immediately start flooding the abdominal and potentially thoracic organs with liters of specially formulated ice-cold preservation solution.
Why cold?
The rapid cooling is critical. You want to drop the core temperature of the organs as quickly as possible, often down below 10 degrees Celsius, sometimes even 4 degrees, within minutes. This extreme cold dramatically slows down cellular metabolism, basically putting the cells into a state of suspended animation. It halts, or at least drastically reduces, that damaging metabolic activity and preserves the remaining energy stores. It buys time.
It sounds like an absolute surgical sprint. But there's another layer of complexity, isn't there? The team has to be ready for this sprint, but they also have to manage the fact that the donation might not even happen if the patient doesn't arrest quickly enough after support is withdrawn.
That's right. That's the major practical limitation inherent in the DCD process. Every transplant center, every OPO establishes a predefined time limit for that initial withdrawal phase. It's usually somewhere between 30 and 60 minutes.
30 to 60 minutes from when?
From the moment life support is actually withdrawn until the patient's heart completely stops beating until a systole occurs. If the patient's heart rate or maybe their respiration continues, even weakly, beyond that specific cutoff window, that period is sometimes called the agonal phase or the observation phase, the donation procedure has to be canceled.
Why that hard time limit? If the heart is still beating, isn't that good?
Not necessarily in this context. Even if the heart is still beating very slowly or weakly, the patient's blood pressure and overall circulation are often critically low during this phase. So the organs aren't getting adequate oxygen anyway. Functional warm ischemia, that low oxygen damage, is already occurring even before the heart fully stops. Going beyond that 30 or 60-minute window means the organs have likely suffered too much cumulative ischemic injury to be safely transplanted. The risk of them failing in the recipient becomes too high.
And we touched on this. This results in a pretty high cancellation rate for planned DCDs. That must be incredibly difficult for everyone involved, the family who consented, the waiting OPO team.
It is. It's emotionally and logistically devastating. The numbers vary by center, but somewhere around 30%, sometimes even up to 40%, of planned DCD cases ultimately fail for this exact reason. The patient either stabilizes unexpectedly or simply takes too long to reach circulatory arrest. It really underscores how complex and, frankly, fragile this pathway can be. It requires mobilizing huge resources, surgical teams, or time OPO staff that often, heartbreakingly, do not result in a life saved through transplant.
But when it does succeed?
When it succeeds, it can save multiple lives from a single donor, which is precisely why there's such a drive for innovation, constantly striving to improve those odds, to make the process more reliable, and to salvage more organs even when ischemia occurs. And the biggest game changer here is a technique called normothermic regional perfusion, or NRP.
Okay, let's really do a deep dive into NRP, normothermic regional perfusion. That sounds sophisticated. It directly tackles that ischemia problem, right? How exactly does it work in a DCD situation?
It is sophisticated, and it's truly transforming the potential of DCD. So in standard DCD, like we just described, the whole strategy is rapid cooling to slow metabolism down. With NRP, the goal is different. It's actually to reverse some of that ischemic damage after death has been declared.
Reverse damage in a body that's legally deceased. How is that possible?
Okay, so here's how it works. Once the legal declaration of death by circulatory criteria is finalized after the heart has stopped and the mandatory standoff period is complete, the surgical team places specialized cannulas similar to those used for heart-lung bypass surgery. They then connect the major blood vessel supplying the abdominal organs, and sometimes the chest organs as well, to an external machine. Often it's an ECMO circuit, extracorporeal membrane oxygenation.
Like a heart-lung machine.
Exactly.
Yeah.
This machine then pumps warm, that's the normothermic part, normal body temperature oxygenated, and often nutrient-rich blood back into those specific organs within the deceased donor's body. It's regional because the circulation is deliberately confined to the torso, the area containing the organs intended for transplants.
So you're essentially resuscitating the organs in place, almost creating a temporary, localized, DBD-like environment for the torso after circulatory death has occurred.
That's a good way to think about it. You're restoring warm, oxygenated blood flow to potentially reverse ischemic injury, flush out toxins, and allow the team to assess the organ's function before they even remove it.
But when you mentioned earlier, restarting circulation immediately throws up massive ethical red flags. How do you possibly do that without violating the dead donor rule? If you restart circulation, aren't you potentially resuscitating the patient, especially the brain?
This is the absolute linchpin. The critical ethical and technical safeguard built into every single NRP protocol. To ensure the patient remains legally deceased, to uphold the dead donor rule while the organs are being perfused and potentially resuscitated, blood flow to the brain must be absolutely, positively, permanently blocked before that NRP circuit is turned on.
Permanently blocked before you restart flow to the body.
Yeah.
How is that done surgically?
There are a few established methods. Often it involves the surgeon surgically clamping or ligating, tying off the major arteries that lead up to the head. Specifically, the branches coming off the aortic arch, like the carotid arteries and the innominate artery. Another common technique is to place a special catheter with an inflatable balloon inside the aorta, positioning it above the level of the vessels going to the brain. They inflate the balloon and it physically blocks any blood from flowing upwards towards the head.
So the warm, oxygenated blood being pumped by the ECMO machine can only go downwards, perfusing the organs in the chest and abdomen designated for recovery.
Precisely. The brain remains completely ischemic, cut off from this restored circulation. This ensures that the criteria for circulatory death are continuously met, even while the torso organs are benefiting from reperfusion.
That's an incredibly complex, highly intentional technological intervention. It's designed solely to bridge that gap, upholding the absolute non-negotiable ethical standard of the dead donor rule, while simultaneously using technology to maximize the medical gift, the viability of the organs.
It truly is. It's a remarkable example of medical ethics driving technological innovation. And that innovation, NRP, is what dictates which organs are now becoming reliably viable from DCD donors. It allows transplant teams to significantly expand the usable pool beyond just kidneys.
So NRP is boosting the yield.
Dramatically. Kidneys, of course, remain the most common and robust, but livers and lungs are now used much more frequently and successfully from DCD donors, specifically because NRP can effectively wash out those damaging metabolites built up during ischemia, and it allows the teams to assess the organ's metabolic function and health before committing to transplanting it. And the biggest leap, DCD heart transplants. Essentially impossible a decade ago. Now a growing reality almost entirely thanks to NRP or similar perfusion technologies.
Okay, so we've got the complex ethics, the challenging procurement, the innovative tech like NRP. But ultimately, none of that matters unless the recipient does well, right? The donor pathway, however complex, only matters if the person receiving the organ achieves long-term success. So the big question, given all those logistical hurdles that initial warm ischemia hit, how do DCD organs actually perform in the long run compared to the gold standard DBD organs?
Yeah, this is where the story becomes really encouraging. The outcomes are, frankly, one of the greatest success stories in modern transplantation. But we absolutely have to acknowledge the initial challenges, especially, as you might expect, with the organs most sensitive to that early ischemic hit, like kidneys.
Okay, let's start with kidneys then. We know they're more resilient, but DCD kidneys often face an immediate problem right after transplant, don't they? Something called delayed graft function.
They do. DGF, delayed graft function. It's significantly more common in kidneys recovered through the DCD pathway. If you look at major registry studies, the rates of DGF can be quite high, sometimes up to 45% or even 50% for DCD kidneys.
45%. Wow. Compared to what for standard DBD kidneys?
Compared to maybe 15% to 20% for typical DBD kidneys, so it's a substantial difference. And DGF means exactly what it sounds like. The transplanted kidney doesn't just wake up and start working immediately upon reperfusion in the recipient's body.
So what does that actually mean for the recipient in those first days or weeks after the transplant surgery?
Clinically, it means the patient will likely need to continue or restart dialysis for a temporary period after the transplant, maybe for a few days, maybe a week or two, sometimes longer, until that transplanted kidney recovers from the ischemic injury it sustained and starts filtering waste products effectively on its own.
That sounds like added complexity, more hospital time, probably more cost, and definitely more psychological strain for the patient right after a major surgery.
Oh, absolutely. It's a significant short-term complication. There's no denying that. It requires careful management, monitoring fluid balance, electrolytes. But the crucial point is that DGF is typically reversible. The kidney tissue can recover.
Okay, so it's a short-term complication. But the really crucial finding, the one that validates the whole DCD pathway for kidneys, is that this initial struggle doesn't seem to doom the long-term success of the graft, right?
Correct. And this is the great reassurance, the key takeaway for kidneys. Extensive studies looking at thousands upon thousands of patients using UNOS data, international registries, they consistently show the same thing. Once those DCD kidneys get over that initial DGF hurdle, once the function kicks in their long-term graft survival rates, and, just as importantly, patient survival rates are essentially comparable to those achieved with DBD transplants.
Comparable at what time points?
At 1 year post-transplant, at 5 years, and even data stretching out to 10 years shows no significant statistical difference in the long run. The functionality might be delayed initially, but the durability, the longevity of the DCD kidney graft appears to be fundamentally the same as a DBD kidney.
That is a really powerful validation of pushing forward with DCD kidney donation, despite the higher DGF rate. Okay, let's move to livers. You mentioned earlier they were historically seen as somewhat inferior from DCD, specifically because of issues with bile ducts.
That's right. Livers are metabolically very active and quite sensitive to warm ischemia. The primary concern has always been damage to the delicate network of small bile ducts within the liver. Warm ischemia increases the risk of injury to these ducts, leading to a serious complication called ischemic cholangiopathy.
Ischemic cholangiopathy.
Yeah. It might not show up immediately. It can manifest months or even years after the transplant. It causes problems with bile flow, infections, and can be very challenging to treat, sometimes unfortunately requiring the patient to be listed for a retransplant. Because of this risk, historically, the outcomes for DCD livers lagged behind DBD. For instance, older data might show 3-year graft survival rates for DCD livers hovering around 65%.
65% compared to what for DBD?
Compared to maybe 75% or higher for standard DBD livers, especially from younger donors. Patient survival might have been closer, maybe 77% for DCD versus 80% for DBD at 3 years. But that 10-point gap in graft survival was significant.
Yeah, a noticeable difference. So how has the transplant community addressed this specific risk with DCD livers?
Primarily through 2 strategies. First, by becoming extremely selective about which DCD donors are considered suitable for liver donation. They tend to avoid older donors, or donors where the functional warm ischemia time was prolonged or where the agonal phase was particularly unstable. Strict criteria.
Better selection.
Exactly. And second, critically, by the increasing adoption of normothermic regional perfusion, NRP. When NRP is used for liver recovery, it allows that warm, oxygenated blood to flush out the liver, wash away damaging toxins, and importantly, it lets the surgical team assess the liver's metabolic health and bile production before they even remove it.
So NRP helps mitigate the risk.
Significantly. And as a result, the outcomes for DCD livers are rapidly improving. Many leading transplant centers that utilize NRQ routinely are now reporting 1-year patient and graft survival rates for their DCD liver transplants that are statistically approaching parity with their DBD outcomes. It shows that meticulous donor selection combined with advanced perfusion technology can really overcome many of those historical risks.
Okay, that's encouraging for livers. Now let's talk about what you called the most dramatic breakthrough, DCD hearts. You said it was basically a medical impossibility just a decade or so ago. What changed? How did technology make this happen?
Yeah, it's truly revolutionary. The heart muscle, the myocardium, is exquisitely sensitive to lack of oxygen. It simply cannot tolerate warm ischemia. Even 5 to 10 minutes without blood flow can cause irreversible damage to the heart muscle. So for decades, DCD hearts were just considered unusable.
What was the paradigm shift?
The key was moving away from the standard DCD approach of cooling the organs as fast as possible and instead moving towards resuscitating the heart after death. This is where NRP, or similar ex vivo outside the body heart perfusion systems, come in.
Resuscitating the heart after death declaration.
Yes. Using NRP, after the legal declaration of circulatory death and the standoff period, the team can cannulate the heart and aorta, connect it to the perfusion circuit, and restart warm, oxygenated blood flow specifically to the heart muscle itself. The heart is warmed back up, it starts receiving oxygen and nutrients, and incredibly, it actually begins beating again on the machine within the deceased donor's chest, or sometimes after removal on a specialized ex vivo device. This allows the team to assess its function, measure metabolic markers, and basically ensure it's viable before transport.
That's just astounding. Resuscitating a heart that was legally stopped. So what are the results? How do these transplanted hearts that were legally deceased and then mechanically resuscitated actually perform in recipients?
The results have been stunningly positive, exceeding many initial expectations. Large comparative studies, particularly pioneering work done in the UK and Australia, and now increasingly in the US, show virtually no significant difference in key survival outcomes compared to standard DBD heart transplants.
No difference, really.
Pretty much. For example, crucial metrics like 90-day survival and 1-year survival rates for recipients of DCD hearts are consistently reported in the 91% to 92% range. Those numbers mirror, and in some studies slightly exceed, the results achieved with traditional DBD hearts.
So the bottom line is, if the procurement, the NRP resuscitation, and the assessment process are done correctly and optimized.
A carefully selected DCD heart appears to be functionally equivalent, providing comparable short and medium-term survival outcomes to a standard DBD heart. It's opened up a whole new, significant source of hearts for patients desperately waiting.
Truly a game changer.
Yeah.
Okay, finally, lungs. They seem fragile too, but you mentioned DCD lungs have also made a substantial impact.
Yes, lungs are delicate, absolutely. They're susceptible to injury during the dying process and from inflammation. However, they seem to tolerate the DCD process relatively well, perhaps better than initially thought. They benefit immensely from the rapid cooling protocols, and their unique structure, being air-filled, allows them to be flushed effectively and assessed quite well for function, often using ex vivo lung perfusion EVLP systems after recovery.
So the outcomes reflect that tolerance?
They do. Large registry data analyses confirm this success. The outcomes for DCD lungs have essentially reached near parity with DBD lungs. 1-year survival rates for recipients are holding strong in the high 80% range for both DCD and DBD donor types.
High 80s for both.
Exactly. And the significant number of DCD lungs now being utilized directly contributed to hitting that record number of overall lung transplants performed in the U.S. in 2024, over 3,300. It represents a massive clinical gain, getting more patients with end-stage lung disease off the waiting list.
So across the board, kidneys, livers, hearts, lungs, the data seems really clear now. DCD isn't some second-tier fallback option anymore. It's a proven pathway delivering excellent long-term success, provided those initial procurement challenges are managed effectively with careful selection and advanced technology.
That is absolutely right. And it brings us full circle, really. We've talked about the ethics, the definitions, the innovations like NRP, and the successful outcomes. But we absolutely have to circle back and emphasize the critical importance of that central logistical phase, the procurement process itself. It's not just a surgical step. It truly is the essential bridge. It's a complex, highly coordinated sequence of activities that directly ensures the organ viability and the positive outcomes we just discussed.
Okay, but we've already talked a lot about the timing, the warm ischemia, the surgical rush in DCD. Why does the procurement step itself warrant its own sort of focused look here? What makes it more than just the surgery?
Because it's about so much more than just speed. It's about precision, coordination, and maintaining a delicate biological balance under extreme pressure. Think about maintaining organ viability. Yes, rapid cooling is key, but it has to be done correctly. The moment the surgical team initiates that preservation flush, the organ must be cooled rapidly and uniformly. This requires precise placement of cannulas, ensuring the cold preservation solution, which isn't just saline, it's a complex cocktail of electrolytes, buffers, sometimes oncotic agents designed to protect cell membranes and halt that destructive metabolism perfuses the entire organ effectively.
So poor flushing technique could damage the organ. organ.
Absolutely. If the cooling isn't fast enough, or if parts of the organ aren't flushed properly, you can get patchy cooling, ongoing ischemic damage in certain areas, or even injury from the preservation solution itself if the pressure is wrong. The organ might look okay superficially, but it loses viability. It's a technical skill.
And that clock we talked about, the ischemia clock, it doesn't just stop when the organ is cooled in the donor hospital, right? There's the whole transport time, the cold ischemia time.
Exactly. That's the next critical window. Transplant success is highly, highly dependent on minimizing the total time the organ spends preserved outside of a body, even when cold. That cold preservation solution buys valuable time, but it's a limited amount.
How limited?
Well, it varies by organ. A heart is the most sensitive. Ideally, it needs to be transplanted within 4 to 6 hours of being removed from the donor. A liver, maybe 8 to 12 hours typically, although newer perfusion machines are trying to extend that. Lungs are also in that shorter window, maybe 6 to 8 hours. Kidneys are the most forgiving. They can often tolerate 24 hours, sometimes even up to 36 hours of cold storage, although shorter times are always better.
So efficient surgical removal back in the donor hospital, coupled with expedited transport, they aren't just nice-to-haves, they're fundamental requirements.
They are absolutely fundamental to lowering the risk of complications in the recipient. Complications like primary non-function, where the organ just never works, or severe delayed graft function, or increased rejection rates. Every hour counts.
And talk a bit more about the complexity of the removal surgery itself. I'm picturing it's not just one surgeon, especially if it's a DBD donor yielding multiple organs, or even a successful multi-organ DCD recovery after NRP.
Oh no, it's rarely just one team for a multi-organ recovery. It is a highly orchestrated event. You might have 5 or 6 separate specialized surgical teams working simultaneously in the same operating room.
5 or 6 teams at the same time.
Yes, you could have a cardiac team for the heart, a thoracic team for the lungs, a liver transplant team, maybe 2 separate kidney teams, one for each kidney, perhaps a pancreas team. Each team is led by a procurement surgeon who specializes in recovering that specific organ. They have to work in perfect harmony, following a strict, pre-agreed-upon plan for simultaneous dissection.
That sounds incredibly intricate.
It is. Precision is absolutely paramount. They have to delicately isolate each organ, carefully preserving its blood supply, the arteries and veins, and any associated structures like the ureter for the kidney or the bile duct for the liver. They must avoid any damage to the vessels themselves or to adjacent organs. Even a small tear in a key artery or vein during removal could render that precious organ unusable for transplant into the recipient. It requires immense skill and concentration under pressure.
And all of this incredible surgical precision happening potentially in the middle of the night has to be perfectly synchronized with the organ allocation system itself, the National OPTN list run by UNOS.
That's the other layer, the logistical masterstroke. The local organ procurement organization, the OPO, acts as the central command hub for the entire process. They are coordinating the donor hospital, managing the arrival and interaction of all those surgical teams, and simultaneously communicating constantly with the OPTN allocation center.
What are they communicating?
The OPO is receiving the real-time computer matching lists for each organ based on national policy, blood type, tissue type, urgency, location. They're contacting the transplant centers for the potential recipients, confirming acceptance. They're arranging all the transport logistics, which might be ground ambulance, charter jet, commercial airline carrying a cooler in the cabin, all while keeping an eye on that ticking clock for each specific organ's preservation time. They have to ensure that clock aligns perfectly with the estimated arrival time at the recipient's hospital, sometimes thousands of miles away, where another surgical team is waiting.
Wow. So procurement isn't really a single surgery at all. It's this incredibly complex, time-sensitive, ethically bound, multi-team logistical coordination exercise.
That's exactly what it is. It's the entire foundation upon which successful transplantation rests. Proper procurement ensures strict adherence to the dead donor rule. It demands surgical precision. It orchestrates the fastest possible transport. It guarantees the organs are tracked, preserved correctly, and allocated fairly according to national policy. Ultimately, an expertly procured organ, whether from a DBD or a DCD donor, is what gives the recipient the absolute best chance for immediate function, minimal complications, and long-term life-saving success. It's the crucial, final, and incredibly complex link in the chain that starts with the donor's generosity and ends with the recipient's renewed life. #TagOutro.
This deep dive, it really has explored a world of, complex ethics, some frankly staggering logistical hurdles, but also immense medical success, hasn't it? If we try to just distill everything we've unpacked today, it feels like two major findings really stand out for you, the listener.
I think so. First, donation after circulatory death, DCD, it's absolutely not a marginal source anymore. Not at all. It is a massive and frankly mandatory contributor to the organ pool. We saw the numbers now representing 43% of all deceased donors. And crucially, it's serving as the primary engine of growth, the thing allowing the U.S. transplant system to even try and keep pace with the overwhelming demand from over 100,000 people currently waiting for a life-saving organ.
That growth offsetting the DBD decline is key. And the second major finding.
Second, and perhaps just as important, is that thanks to these pioneering techniques, especially normothermic regional perfusion and advanced machine perfusion, DCD organs are delivering excellent results. Despite those inherent challenges of warm ischemia, despite higher rates of short-term issues like delayed graft function in kidneys, the long-term survival rates being achieved are comparable and often functionally identical to those we see from traditional DBD organs. And that's across the board now: kidneys, livers, even hearts and lungs.
The outcomes are holding up.
They really are. And the continuing goal, the clear focus for the entire transplant community remains twofold. Keep refining those DCD protocols, improve the selection criteria, enhance the perfusion technologies, and through all that, increase the yield per DCD donor. Get that average of 1.8 organs recovered closer to the 2.8 average we see from DBD donors. Because every single additional organ recovered and successfully transplanted is another life saved. It's that simple.
It really makes you pause and consider the profound, almost delicate balance that's required right at the heart of this entire system. You have the absolute strict adherence to the ethical standards, the fact that the patient must be definitively, irreversibly deceased before anything happens. That's completely non-negotiable.
You're compromised.
Yet on the other hand, to maximize the chance of saving another life, the medical teams are resorting to these truly extraordinary, complex technological interventions.
That's exactly right. And it creates this necessary ethical compromise, if you will. Using machines like NRP to temporarily restore physiological function to organs within a deceased body, while simultaneously ensuring, through surgical or mechanical means, that the brain remains permanently non-perfused to uphold the definition of death. It forces us as a society and as a medical community to continually re-examine our definitions. The definition of death itself, the boundaries of medical possibility, the limits of intervention.
So this innovation, this technology like NRP with brain flow blockage.
It's the crucial balance point, isn't it? It's where the technology allows us to bridge the ethical mandate honoring the donor and the irreversibility of death with the profound medical and moral imperative to save the recipient waiting on that list. It's a fascinating and vital intersection.
A truly profound thought to end on for an incredibly sophisticated and fundamentally life-altering process. Thank you for joining us for this deep dive.